Okay, welcome everyone for this departmental inaugural lecture by Professor Gijs Van Pottelbergh. Gijs joined our department as professor from the 1st of October, so welcome Gijs in our department. And Gijs defended his PhD in 2013 on the diagnosis and outcome of chronic kidney disease in older persons. And since May 2015 joined the Intego team focusing on chronic diseases and their evolutions over time. And he has been responsible for Intego environmental projects funded by the Flemish government. I'm sure you will tell more about that. He's as well co-founder of Zorgzaam Leuven, a network that focuses on reorganization of primary and transitional healthcare in Leuven, and he combines his professorship with as well work as a GP. Gijs, the floor is yours. Thanks. We can't hear you, Gijs. Just unmute.
Okay, I'm back. Okay, so thank you all for listening. I'll try to make it a nice talk. What I'm going to talk about is, well, I'm going to start with some relevant changes for healthcare. I'm not going to go into depth in that, but of course I have to situate why we are doing the things we are doing. And then we are fast going to that the problem in real life we try to solve is very complex. And those who were a few weeks ago on the lecture of my colleague Nicolas, he already talked a bit about real life data and stuff. So I'll try to show what we are doing with that real life data, or trying to do with that real life data. I'll try then to focus on the solution and why we're trying to get data to solve a part of the problem in real life. And then I'll go into detail in what we call building the Intego 2.0 machine, and then why we can use this machine for.
Okay. So, Gijs, just to interrupt you, we don't see your slides anymore.
Just a moment. Sorry for that. Try it again. I should be back, eh?
Yeah, we see your slides, but not in presenters mode.
Is that possible? Now okay?
Yeah, perfect.
Okay. So what are the challenges for healthcare? Well, I just picked one. Of course, we could have about enormous technological evolutions. We could have it about that we should involve the patient, the person, of course. But the main focus of what I'm trying to solve is the increase in chronic diseases and all the problems related with that. And this is a slide showing the proportion of people with multimorbidity in different age groups. It's a slide from a few years ago from the Intego data network, but it shows very clearly that in different age groups, the prevalence of and the prevalence and the incidence of the prevalence of multimorbidity is increasing. And that's a very difficult problem for us as clinicians, of the clinicians working in real life care, because multimorbidity it's something that's not so easy to tackle. So we see more people having chronic diseases, having longer chronic diseases, more people taking more medication. That generates a huge amount of health costs. And there are estimations that like 70% of the health budget is spent on chronic diseases. Of course, it depends on how you count and whether you count them or not. But that's one of the starting points of many of the actions, many of the projects I'm involved in currently, and I will be involved in the next year, how to handle this rise in chronic diseases, how to and not just handle it from a medical perspective, but also from an organizational, from organizing the care, from the health costs and so on. So typically what you do in research to study something is you make study cohorts. And that's, for instance, what I did in my PhD. I worked on the BELFRAIL study, Belgian cohort for very elderly. I worked a bit on the Leuven 85 plus data, and we worked on, and I did some work on Intego, the classic Intego data. I will not go into detail about BELFRAIL and the Leuven 85 plus study, although that would be interesting, but are very classic cohort studies where you take something like 700 patients aged 80 and older, and you then do an assessment, and you lead a new assessment, and you collect data. That's a classic way of handling cohort studies. What's the basic Intego? Because I'm first going to talk about the basic Intego, and then the rest of my talk about how we try to make, starting from this basic Intego, something new. I saw that Frank Bindings was also in the call. Frank knows all about this. He spent a lot of his career developing Intego and doing research with it. Well, Intego started when I was still a kid in 1994. Intego collects data from GPs, their health files, their electronic health files, and extracted that data. And the good thing there is that most patients have, year after year, have the same GP, so you can then follow most of those patients in long term. And what kind of data are we extracting? Well, the main data is about morbidities, of course, also about some demographics, drug use, vaccination data, clinical parameters, lab values. So everything that's coded in the file of the GP is collected, of course, there is a pseudonymization, and there is all kinds of aspects involved that are not identifiable in the final database. Very concrete, a patient comes with the GP. What do we register? Well, here in this example, the patient is 65 years old. He comes and he has a high blood pressure, he gets medication, and we take blood. Of that type, he gets a vaccine of that type of a consult, a typical consult in the practice. What kind of data is registered? Well, of course, the age and the gender. There is a registration of hypertension, that's a diagnosis with an exact date. There is a prescription of a certain drug, in this case Ramipril, again with a dose and a date. There is an influenza vaccine that's admitted, of course, also with a date. And then if you take blood, you have the exact blood tests, their value, and the date. That's basically, of course, I mean, we do have other types of consult, but basically that's what remains in the Intego database after extraction from the files from the GP. So we don't extract the written notes like patient comes for a high blood pressure, but we we use the coded data. Of course, it's also important to stretch out that to some extent data of what happens in the hospital is also in the files of the GP. Of course, not in full data, but for instance, if someone had a stroke and was therefore hospitalized, the stroke will in almost all cases also be in the Intego database. That's basic Intego. But the problem about what we're trying to do is that real life clinical practice is becoming very complex. What did we see a few years ago? There were all kinds of care trajectories, transitional care pathways, and so on. They have different names, zorgprogramma's, zorgtrajecten, and so on. They were implemented, but that was a difficult start. That was not the solution for the problems we saw. There is a strong increase in the complexity of care. As I said before, we have a very strong increase in patients having multimorbidity. The more we know, the more the complexer multimorbidity and the care for that persons become. We see an explosion of specialisms, subspecialisms, and treatment, and that's not only in healthcare, but also in other types of care. all the types of care. Also a very fragmentation. You see the same fragmentation in primary care. We have financial systems in the healthcare who at least needs an update or needs change. We have very different types of eerste lijnspraktijk, so there's not just one model of a huisartsenpraktijk, of a GP practice. There are different models, different systems. They work differently. We have a limited availability of data, and we're working on that. So most of my presentation will be about how are we trying to get data and trying to use data. And if you look at from the patient's perspectives, a lot of patients are happy with our healthcare system. A lot of patients do get lost, do not find a solution, struggle with the complexity of our healthcare system, get referred from one doctor to another doctor and then go somewhere else and again. So a lot of what I call lost patients. So, of course, there are internationally some very interesting concepts on how to improve, how to define good care, how to measure good care, how to improve health. One of those very essential concepts is the triple aim, where you're not going just to measure, just going to use the data from, for instance, a cohort study, but also takes into account the experiences of the patients and takes into account the cost, the cost for the whole population. And of course, there are a lot of concepts also, putting the person in the center of the care, whole story about the community, about the whole story of tailoring the care around the patient. There are very good conceptual documents about that, but still the real life situation is very, very complex. You have the whole discussion about multidisciplinary, you have the discussion about patient-centered care, you have teams and networks, you have the community, you have the chronic care pathways, chronic care trajectories, and so on. You have then the discussions about how to finance this, models like the cappuccino model. You see there the whole discussion about whether it should be a pyramid or a flower. I can assure you a lot of energy is going to that kind of discussions that are often linked to financial issues, financial discussions. You have a huge problem with equity, with access to healthcare. You have a very different health literacy, case managers, and so on and so on. So the point is here I want to make it, of course, there are concepts who can help to solve this kind of problems, but it's not just solved with a concept. The concept is just the beginning of a solution, because the solution is very, very difficult. And then a small bit of history of the last 10 years. In 2012, there was a very important paper from the KCE about the organization of care for chronic patients. Then there were, of course, a lot of echoes and a lot of conferences and stuff after this paper and before this paper. And in 2016, there was a call launched for a national plan, a 5-year plan with integrated care projects. And in 2008, 12 of those projects started, and I'm very proud to be one of the coordinators of one of those projects. It's a Zorgzaam Leuven project, which takes together a lot of local organizations trying to make steps towards more integrated care in the region of Leuven. Of course, with the ideas that if it works in this pilot, it could be transferred to other regions. And just to show you what is such a project doing, well, that's quite complex. That's not just one action. We made a reversed pyramid based on Kaiser Permanente and other models. With patients, we divided the care actions into chronic care actions and what we call episodic care actions, so shorter, limited time actions who need for periods where the patient has a higher care need. And on the other hand, you have the typical chronic care. we divide it into actions, and you see there we have, this is for instance what currently Zorgzaam Leuven is doing in Leuven regions. We have actions, we are implementing a zorgmodel called buurtteams with a lot of actions about different types of patients, including zorg coordination. We have a lot of projects around good, correct use of drugs, including deliveries at home. We are working on daily advice from specialists or advices on a distance. We are working about shared care, that the diabetes care is coming into the nursing homes. We are working on case management. We have actions with after, before and after helping young mothers who need more support, and so on and so on. We have actions in neighborhood teams. So it's implementing integrated care is like a very complex puzzle with a lot of different pieces. And of course, you can say the pieces are in category, but still, it's not just one action. It's very, very complex. It are different action lines. It are a lot of actions, and of course. If you want to measure the impact of this complex system with a lot of actions and changing actions, you need an instrument that's able to measure all of this. And then comes in our idea, which we are working for a few years already, about making what we call Intego 2.0 monitoring machine. And the reason why we want to make this monitoring machine is we want to be able to measure that AAA, which is complex and very different aspects to measure. We want to do that using real-life data with a limited time delay. It's very nice for research if you can measure 2 or 3 years afterwards the effect of an intervention, but if you want to implement integrated care, you cannot wait 2 years for having feedback on the results of your actions. We want to do that on a regional level. In the case of Flanders, it's on the so-called eerste lijn zones. And we want to do that for local monitoring, but of course also for national monitoring and research. So that's a bit what we're trying to do with Intego. And this is the one slide model that we are trying to implement. What's the idea you see in the left below? We are starting from the data who are in the electronic health records of the GPs. We are transferring that data over eHealth to health data, which is a secure environment where the data then can be linked with other data sets. For instance, the data from the Intermutualistic Agency, the data about all the costs, all the codes used linked to health costs. And then in that analyze environment, we can do analysis. It can be used for scientific research, but also for public use and policy making, both on a local level or a national level. And the things we are trying to add to that system is, because we did make that loop already. Yeah? So we are in the health data environment. We are able to have output. We are working on the output on a very local level. I'll show some examples later on. But the things we are trying to add to that system is, first of all, making the pool larger. But then we have been working on adding environmental data. We are struggling with trying to get the input from the patient himself, him or herself. Would try to get data there to know what the patient's thoughts are, what the patient's perceptions are, and then of course more and more data is also coming from synchronization. For instance, if now you go to a vaccine center and they give you there a vaccine, this data will synchronize with the files of your GP, and of course then will also be Intego. So we have kind of a 10-year plan, and I always say we because it's in very close collaboration with Bert Vaas and of course the rest of our team, but I work very close together with Bert. And a kind of 10-year project to make this all happen. We did move towards eHealth towards health data using eHealth. We expanded our network. We have a test. We have realized a test linkage with IMA. We have struggled very hard, but we made it possible to link with environmental data. That means that, well, I'll come into detail that later on. We are now restructuring our database and looking into how to balance that data, and especially the geospatial analysis, very, very complex. How are we going to do that? Because we want to have a full coverage of all the 60 eerste lijnzones of Flanders, or as much as possible of those 60 eerste lijnzones. We are starting a trajectory on involving the patient as a partner and a source of data. I just came from a defense of an internal proposal to expand the Intego data collection also to nursing homes, and we are constantly working on audits and feedback. So out of all this, I will focus a bit on linking with the environmental network, because that's what I was been working on the last years. That will show a bit of in detail what we're doing, but it's important to see it in a bigger picture. So what did we do, or what did we try? Well, we tried to link environmental data with health data. It was a project funded by the Flemish agency, and the main goal is to link real life data, for instance morbidities, with outdoor pollutants and other environmental factors. Why would we try to do that? What's the relevance of that? Well, there is like a ton of literature on the effects of, for instance, air pollutions on different diseases, respiratory diseases, cardiovascular diseases, a lot of things around birth and birth weight, premature birth and birth weight, but also evidence that it has an influence on the onstart of diabetes, high blood pressure, and so on. So there is quite a lot of data that there are short-term and long-term health effects of air pollution, but also of noise, the temperature of heat, or heat stress, and so on and so on. So linking that is relevant. Why? Because of course then you can measure the impact of that on health in Flanders, and if you have a monitoring instrument, you can also see the impact of interventions. If you try to do something, if you, for instance, change traffic rules in a certain city, you could use, if you have an instrument, you could measure, you could analyze the effects on health of all that. If we are talking about the health impact of all these factors, the mostly used variable there is the outdoor exposure. But of course, as this graph shows, that it's not just that outdoor source has a direct impact on health. The impact of health comes from an exposure dose. An exposure dose that's of course related to how much are we breathing, in what kind of circumstances, are we inside or outside, and that then again it's related to stuff like ventilation and so on. So that's a very complex relation, but in general, in almost all international research, especially on large-scale research, outdoor sources of exposure are used as a proxy or used as the measurement for pollutants. But know that it's very complex. And so what you do, what kind of a building you do, and so on, is of course also some relevance. And because there is a whole set of environmental data available, they're made on maps and cards. They are analyzed, they are available, they are public available, and they are very detailed. For instance, on 100 by 100 meters, there's an estimated measurement for that place for the whole maps of Flanders, and you see there the whole list. We do not make those data ourselves, we're using the data, but it's about air pollutants, it's about traffic parameters, distance to green spaces, noise, and then temperature and temperature-related heat stress parameters. There's a lot of data on that, and so the goal of this project was to combine these data sets, available data sets, with the health data in the And the real challenge is, of course, that you need to combine those data, but still be sure that the person with which his data, his health data, is in the system, is in the database, is of course not identifiable. Yeah? So that means that you do need to use addresses, because you need to have the outdoor concentration, so you need an address, but on the other hand, you cannot have the address or the medical data at the same time, because then you can identify the patient, because the exact address where someone lives is of course a very strong identifier. And a second very important challenge is the geographical spread of patients. Why is that a challenge? Well, until 5 years ago, Intego was made just to have a representative sample of Flemish patients, and so with like 2% of the population and some parameters, we had a very good estimation. But if we are linking to the environmental factors, there are other things taken into account than just having a sample. For instance, this is the number of hittegolfgraaddagen, is a measurement to express the heat stress on a certain place in Flanders. And you see a lot of differences there in the number of hittegolfgraaddagen. And those differences are not just cities against rural, but you also have the environment. The coast, close to the coast, is something very different than on a sand-based environment. So you need to have those. You need to have enough spread of your patients, not just rural versus non-rural, cities, non-cities, and outside cities. You have to have a good coverage of your map. So that was one of the main challenges. We needed to recruit more practices. We started with around 45 GP practices, and we recruited more than double of, just to increase our data network. And then how does it work? Well, how do we collect data? Well, Intego takes this data out of a GP electronic health system called CareConnect, the most used GP system. And then the data there is extracted, digitally extracted, and we use as an identifier the Rijksregistrering, so the national security number, that's coded, that goes to the EHAD coded, and that goes into a coded number, and then the data goes into the health data. That's a standard procedure. That's how the medical data is transferred. But of course, as said before, to link to this data to environmental data, we need another identifier. We need to have the address, but the address can never be on the same place, in the same data set as the medical data, because of course the medical data, the address is also an identifier. So we needed to have a second data stream who started at the same moment, where we are transferring just the national security number, which is an identifier, who will be coded together with the address. The address is encrypted, so it can only be decrypted by Vito, by the decryption there. And the data is then sent over health data to Vito. So Vito receives the coded national security number and the address. They unpack the address, then they link the address they use the address to collect all the existing environmental factors that are available on that address. They do a matching, of course, of the address and the exact location on the map, and then link all the environmental factors to that location of the map. They delete the address, and they just send the coded national security number with all the environmental factors known for that exact location to health data, where health data then link the second data stream with the first data stream, and then you end up with a database combining environmental factors with health factors, and they are linked for the individual patient on his home. Very good system, although very good system, but of course that was quite a lot of work to construct it. You need to have all the privacy and other authorities convinced that it's fully okay. You need to describe it all in full data, so that takes quite a lot of time. If someone wants to read it, well, you here see the full references of all our applications there. but this system did not work. Very surprising for us. Why did it not work? Well, it took us like a year of our time, my time, and also a lot of time of Bert Vaas and others. Why? Well, the problem was when we were using the system, it went very slow. The problem is Intego contains now approximately 300,000 patients every year, so that's approximately. And then we needed to collect the data from all those patients, and all that data needed to be coded by the eHealth system. And there are two options to try to get your data past the eHealth coding system. One option is send small packages, but if we send too much packages, the system crashes. And the other option is then send it as a bunch of data. We talk about gigabytes of data, but we did it, but apparently it took months to decrypt all this, because you need several encryption layers to decrypt all this, a very complex process. It really took months for the data purge. Then of course you go looking and you see, are we doing something wrong? And apparently it was not a problem of Intego, it was a general problem of the whole eHealth system, and we needed a new way of handling those data. And after a lot of discussions and a lot of simulations and tests and so on, the conclusion was we need a new data split. And I'll show the data splits right in a minute. And the main conclusion of the data split is that it works very fine now. What is the data split? This is a bit technical, but instead of sending all the data through the eHealth codage, we only send the person's ID to the eHealth codage, so not the medical data. And the medical data is, together with the technical ID, is referred outside eHealth to health data, where again all the data is brought together. This, of course, can be reversed, but this sounds very, very simple, but I can assure you it took like a year of time and dozens of meetings to be able to solve this. Why? Because it was a general flow of eHealth who needed to be changed. So as Intego, we kind of needed to change the eHealth coding system just to make sure that it's possible, but now it works very fine. It even works that fine that we now collect data on a weekly basis, which is a huge progress and allows us, for instance, to monitor stuff like COVID and other things almost in real time. So then, of course, one of the other very interesting moments was to see whether we were able to match the data, because if you have someone's address, well, you need to be able to geocode it, to transfer it, to link it to an exact location on the map, and then, of course, it needs to be able to then you get all the environmental factors. So that's, we sent in all our historical data. You see here the numbers, more than 500,000 individual patients, their addresses, patients were sent by the system. We notified that approximately 10% of them had no address. That's mainly the historical data. I remember we are collecting data from 1994. At that time, we didn't read EID cards and stuff like that, so some of the addresses were missing. But of those of which we had an address, we managed, or Vito managed to match 96% of them to an exact location on the map, and then were able to link environmental factors to that location. So we now have, after 4 years of trying, failure, and an eventual, and at the end success, we have an Intego milieu database. And what can we do with the database? Well, of course, we can do surveillance of known association. Typical stuff there is where the government is interested in visualizing and monitoring the association between, for instance, distance to road and cardiovascular or respiratory diseases. But on the other hand, of course, you can use this data set for new research, new hypotheses. For instance, looking at the subgroups of patients who are more influenced by heat stress than others, or that recently started a PhD on that topic, looking at the association between environmental factors, different environmental factors, and mental disorders. So again, our 10-year project, I'll explain a lot about the linkage with environmental projects, with the environmental network, but know that we are working on several other parts of the map as well. Because what's the goal? As said in the beginning, we are trying to make a monitoring machine out of Intego. And what kind of monitoring are we trying to do? Well, we try to monitor the impact of relevant intervention on healthcare. And then you, of course, need a broad set of parameters that you can see the impact in different domains. We're trying to do that for research, but also for local projects. And we are setting up a system where you have a general visualization, a general availability of data, and then, of course, in-depth analysis where needed, and the visualizations are in progress. When I was preparing this presentation, I was allowing myself only 1 or 2 slides on COVID, as a lot of other people had quite enough of all the COVID stuff, but on the other hand, it created some opportunities. So one of the things that's now been done, and that's not based on Intego data, but we had an advisory role in trying to create all this, is that the COVID-19 infections are monitored in the Zorgzaam Leuven by the Flemish government. And for instance, this is the basic map you see there, where you can see in general what's the evolution of the COVID-19 pandemic in regions. And of course, if you go more into detail, you can go into the level of statistical sector and so on, and you can see who is infected and trends and so on. So there has been made a huge progress in visualizations and monitoring of diseases due to COVID. And as an Intego team, we are ready to expand that knowledge to other diseases, other medical problems, as soon as COVID starts to taking over time. So what are we working on at this moment? As said, we have a 10-year plan. You see you see the list of the ongoing PhDs of the Intego team. So we're working on longitudinal models. We're working on a framework to analyze all the data. We are, of course, we're working on disease management programs and constructing new care models. And then, as said before, we're also looking into the association between factors of environmental factors and, in this case, mental health, but the same could be done for other diseases. And we're not alone. As said before, in Intego, we are a network, but we are also now collecting data together with Cienzano from a very large network of practices. We work together with the other colleagues who are gathering data from primary care, and it's mainly Cienzano, and then for some parts UGent and the Antwerpen, and we have some contacts with Titel and Domusmeter, have some plans as well. And it's a bit on a low level, functioning on a low level now, but in 2019 we started to construct a European network who is trying to gather all this data, because of course international comparison is very, very relevant. Do we have limitations? Of course we have limitations. We have very strong limitations as Intego. Well, we are focused on primary care data. That means that of course you cannot collect. A lot of questions need to be answered by different data sets, of course. Real life data is incomplete. We are struggling with that all the time. That means that you don't have, for instance, a blood pressure of every patient of 30 years old. Only when they came to the doctor for a medical problem and the doctor measured the blood pressure and noted it down in the file, you have a blood pressure. So in all of our research, we struggle with incompleteness of the data. Of course, we have ways to handle it, and there are ways to handle incomplete data, but it's a very, very important problem, especially with longitudinal analysis. We are not built to analyze rare diseases or very short-term time periods or very short, very small areas, and we have a lack of data in small children. But to conclude, We are building Intego 2.0, and we are convinced, and every year we are more convinced that it could be a very good solution to solve a lot of research questions mainly about the whole complexity of the care, because the measuring quality of care in real life is complex. And that's not so easy, but we try to solve that by taking Intego step by step more towards a real monitoring machine. And one final message, of course, I'm very curious about questions. It's always a nice part of the speaker if you get questions. But we are open for all kinds of collaborations. To be clear, we don't have a very large research team who is able to analyze all the data we have. We have a lot of data. We are very open to collaborations because we are not able to analyze all that data alone. So if any of you has ideas, please contact myself or Bert Vaas. We really encourage the use of our data for all kinds of projects and master theses, PhDs, and so on. Of course, it should be feasible for us to do the analysis, but we are really open. And now I'm going to stop sharing all this.
Okay, thank you very much for your presentation. I'm looking in the audience for questions. You can type in the chat as well. Maybe a starting question. How easy or how difficult is it to extract quite a lot of data if you compare with a lot of other studies? You refer to it, you have a lot of prospective disease studies that are being developed. I mean, do you see a kind of a match or additions to really studies that have this kind of design?
Yeah, then well, from a technical point of view, how to extract the data, when you need to make the data float, it's very complex. But once it works, it's routinely done. So the change there. But the real question is, of course, how relevant is the data we have? Well, we do that kind of exercises very often. For instance, if you're talking about flu. With the incidence of flu, we match that then with the Zorgzaam network, who is using data from BELFRAIL, from sentinel practices, and it matches quite well. So we did in the past a lot of, as a team, we did a lot of matching with other results, and for most of the cases there is a very good match. But all depends, of course, on what are you measuring, because if it's a disease or it is a problem that is not under scope in primary care, in the GP practices, then of course it's not measured in our data. But for the general things, we can compare this quite well with international data, and there are also ways to correct your data. For instance, the prevalence of diabetes, you can use the coded diagnosis of diabetes. You can also use blood results to correct for missing in coded diagnosis. So we do know how to handle this, and in most cases we do match quite good and even sometimes very good with other sources of data. But of course it has its limitations. It's not a cohort study, it's live data. But on the other hand, the big bonus is that if once you have constructed a system, of course you get your data automatically, and you get them year after year, and you have a lot of data to availability.
I see there are two questions coming in. Maybe Helene Schoemans can start.
Hi, Gijs, do you hear me?
Perfect.
Okay, great. So thank you for your great presentation. I was just wondering, does Intego actually take into account psychosocial variables like education status, income, health behavior like smoking? It's unclear to me how Intego really collects the data. Is it extracted from what the GP puts in, or do you have like a CRF form?
We use what the GP uses in clinical practice. That means, do we have data? Well, for instance, we have smoking status, but we have it incomplete because it's not for all patients. It's not filled out. But for instance, one of our PhD students is working on how to then use the incomplete data to make it more complete, or to make it more complete for analysis. But that's one of the things. Do we have stuff about lifestyle, smoking habits? Yes, we have it, but as to the extent that it's registered by the GP, so that's incomplete data. We have some data. Everyone is coded in the healthcare system with some codes suggesting whether they have a high income or whether they have a low income or not a low income. But we don't have, for example, educational level. That's one of the things missing. And that's one of the parts where we want to work on the next years, that we really want to involve the patient as a partner, and not just for the data gathering, but also in the clinical practice. That there are systems to share a part of the medical files with the patient. And then, of course, if the patient can fill in a part of his data and it comes into the GP files that's relevant for clinical practice, for instance, for case finding, who should you contact to do a spirometry to screen for lung problems related to smoking. You only can do that if you have the smoking status. And if then the smoking status is in the files, we also can collect it for scientific research and projects. So that's one of the main things we are still struggling with, but on the other hand, it increases. And the newer versions of the medical files encourage more registration of that kind of lifestyle parameters than it was before. So we are making progress, but we are not there yet.
Okay, thank you. And there is another question from Jean-Marie de Grijs. Jean-Marie, can you express your question personally, or do you want me to take it? So it was in the chat. I'm not sure, maybe he has a problem in connecting. The question is you are depending on the data, how it's entered by the participating physicians. Is there any quality control mechanism on the registration of this data?
Yes, of course. I left that part out because of the time and the story I want to tell, but that's a very important thing, of course. You need to have enough qualitative data. So that's yeah, we do depend on the registration. We have several processes to try to solve or try to check quality. We have some indicators, for instance, enough diagnosis of the GP should be coded correctly, because only when the diagnosis is coded correctly, it's linked to a code, and then you can use it for sure. Free text diagnoses are not so interesting to analyze, although there are methods to analyze and they're very complex. So, for instance, that percentage is very relevant. The amount of diagnosis you have as a GP also is taken into account. So we only use the data from practices of which we are quite sure that they register enough coded diagnosis. That's one part. Some part of our data are coming from lab results and stuff like that. Yeah, well, then it's coming directly from the lab into the files of the GP. We are quite sure about the quality. But of course, we have all kinds of processes, because you can get false values. And the typical is blood pressure. You can notice as 14 or 1400, and of course you need to correct that when you're using analysis. So we have all kinds of we have developed all kinds of mechanisms to try to correct the data we receive, because we are very well aware that there are sometimes often problems in the registration or in the completeness of the data. So that's a daily struggle trying to improve that. But one of the things we are doing at this moment is giving feedback to the practices to the practices of which we use the data. So we give them feedback, they can compare themselves with others, and also to install audits in the files of the GPs. For instance, that they can go look for patients who have diabetes who are not coded in their files as diabetes. And before you needed to program yourself a query, but now you make a button and you click the button and you see. So we are from different ways constantly trying to improve the data, and we are always aware of the limitations of our data.
Okay, thank you. And Geert, do you want to ask your question?
It's a very practical one. I heard that finally the difficult process of getting data from CareConnect has succeeded. When can we attend to have these data at the website of Intego?
Yeah, good question. I don't have the answer yet for sure. I should ask Bert. He's trying to involve that. That's one part of the answer. The other one is that the plans we had or be changed due to COVID. So now we are working with a health stat environment where we can get feedback, and we can get feedback on the level of an individual practice. If you log in with your ID, you can see for your own practice a set of parameters. Now at this moment it's a set of parameters related to COVID, but as soon as COVID goes down, we will make a set of parameters elsewhere. And of course, we have a set of data, that is available on the website, but it's not updated at this moment. So I don't have an exact timeline, but we are working on that, and it should have been done already. But yeah, it was 11 months of COVID, so it's a bit in delay. But I'll keep you informed, or Bert Vaas keeps you informed.
Okay, thank you. I think with this, in view of the time, I need to end the session. I would like to thank you and for your nice presentation, and thanks all the participants. The next presentation is on the 9th of March. Then we'll Professor Helene Schoemans will then give us a lecture. Thank you all, and see you next time.
Ja, dat zal wel. Ja, bij stukken en brokken. Ik heb... Ja, ja, ik ben natuurlijk gebiased. Ja. Dus alleen, je hebt uw week wel. Hè? Eerst de C2, dan en dan de zaterdag nog eens. Nou, dus ik ben lid van de ethische commissie Zorg in UZ Gasthuisberg. Dat is een ander dan de ethische commissie van het onderzoek. En de leeftijd van 65 is daar onverbiddelijk. Dat wil zeggen dat ik moet vervangen worden. En eigenlijk hebben wij een traditie dat daar altijd minstens één huisarts in zit. Voor mij deed Jo Lizarde dat. En daarvoor heeft jarenlang Jan Krane dat gedaan. En ik vind dat eigenlijk wel belangrijk, want er zijn toch een heleboel elementen waarbij dat het de insteek vanuit de huisartsgeneeskunde / eerste lijn toch belangrijk is. En dus is de vraag waar dat vandaag geen antwoord op moet komen, waar dat jullie misschien wel eens moeten over nadenken. Wie mogen wij voordragen? Want dat is niet zomaar de leepleider die zegt wie dat in zijn plaats zal komen. Bert moet dan iemand voordragen en dan moet al de geledingen die we daar hebben passeren. En men vindt dat eigenlijk toch wel een belangrijke positie. Allee, belangrijk in de zin van, je bent daar eigenlijk voor ja, toch een brede groep van de mensen van de faculteiten van het ziekenhuis zichtbaar. En de decaan en de CEO weten zeer goed wie dat daarin zit en wie dat daar niet in zit. Dat is... Ja, Martijn Hiele, de gastroenteroloog, is daar voorzitter van. En welke thema's behandelen die? Wel, een heleboel, bijvoorbeeld, er zijn 3 vergaderingen nu gegaan over de DNR-knop en de VZP-knop. Hoe gaan we, vroegtijdige zorgplanning, DNR, hoe gaan we dat doen, welke procedure en hoe gaan we dat noteren in het KWS en wat zijn daar de consequenties van? We hebben een nota gemaakt in het begin van de COVID-crisis met betrekking tot prioritering naar intensieve zorgafdelingen. Een nota die nogal wat weerklank gehad heeft in de grote pers. Er is bijvoorbeeld een hele discussie geweest over een nieuwe procedure van de cardiochirurgen over prelevatie van organen bij mensen die klinisch dood zijn verklaard. Al dat soort dingen. Ja, dat is de ethische commissie Zorgzaam Leuven. Ja. Ja, maar toch, daar zijn toch heel wat. Eigenlijk in ieder dossier voel ik mij betrokken en kan ik een inbreng doen. Hè. Als dat gaat over vroegtijdige zorgplanning, ja goed. Als je aan die procedure begint, wat heb je al? Wat heeft die huisarts al gedaan? Hoe weet je dat? Hoe komt dat daarin? Ik geef maar één voorbeeld. Hè. De werkbelasting is één vergadering per maand van 1 uur of 2,5, 3 uur, de dinsdagavond. Die je best voorbereidt, maar die zijn zeer goed voorbereid met één grote pdf waar alle documenten in zitten. En dan soms ook ad hoc vergadering. Bijvoorbeeld, er moet een beslissing genomen worden die niet kan wachten tot de volgende vergadering. Ik zeg maar iets. Er is zwart. En dan roepen ze een aantal mensen bijeen om samen na te denken van, zijn we akkoord dat klinicus XYZ deze beslissing neemt, deze behandeling stopt, enzovoort enzoverder. Ja. Ja. Ja, nee. Ja, dat zijn, weet je, anders moet jij het eens met Martijn opnemen en zeggen van, we hebben 2 kandidaten, hoe doen we dat? Maar ik denk dat jij dat dan moet doen als diensthoofd. Want ja. Nee, maar dat gaan ze niet doen, ze Bert. Dat gaan... Je kunt het hem vragen, hè. Je kunt, maar ik heb dat nog nooit weten gedaan worden. Maar het is een interessant. Oké. Micro. Ja, nu wel. Ah. Ja. Dat je met publiceerbare dingen komt. Wel, we hebben, Birgit zal het bevestigen, de ervaring gehad met dat project aan de VUB, die eigenlijk op centraal niveau van de VUB, maar dat is natuurlijk een kleinere universiteit, een ploeg hebben van mensen die dat eigenlijk doen, waar iedereen kan terechtgaan. En je moet maar een keer zien, maar het aantal projecten en de bedragen van de projecten die binnenhalen in verhouding tot de grootte van hun universiteit, dat is heel sterk hoor. Daar, daar vallen wij bleek tegenuit. Dus ik denk dat inderdaad expertise is die iedereen kan helpen. En ik heb dat gezien bij de ontwikkeling van dat project, dat ze daar voortdurend aan terugkoppelen en zeggen van, je moet dat zo en zo doen en je moet dat schrijven en dat zijn de woorden die je moet gebruiken. Ze hanteren zelfs een document waarin staat welke woorden en termen trendy zijn en die je zeker moet laten vallen om kans te hebben om bepaalde juryleden te passeren. Zo ver gaan die, hè. Dus ja, ik zou daar dankbaar gebruik van maken als we dat kunnen doen. Ja. Ja, maar zeg, we hebben daar een paar keer een beroep op moeten doen. Dat gaat zo traag, dat gaat zo afstandelijk. Mijn ervaring is daar helemaal niet positief mee hoor. Met LRD was dat nog een beetje anders, maar LRD gaat dan meer over de contracten en minder over de inhoud. Nee, wel, ik heb de twee meegemaakt aan de VUB en de KU Leuven. Ik kan u zeggen, KU Leuven heeft daar zwak tegen een zwakke ervaring. Ja. Oh ja, maar natuurlijk. Ja, ik weet niet of een expert in alles moet zijn. Allee, bedoel, die kan dan eventueel terugkoppelen naar het grotere geheel op de dingen. Ja, ik denk, of het is een voorstel dat nogal geleefd heeft 10 jaar geleden op onze afdeling. Hè. Dus zelfs iemand die toen voorgesteld heeft, ik ga dat doen en ik garandeer u dat je 3 keer meer projecten binnenhaalt. Of dat waar zou geweest zijn, weet ik niet, want het is nooit doorgegaan. Maar Ja. Ja, ja. Ja. Online abonnement, hè? Ja. En ik heb het nagekeken, het is echt helemaal gedigitaliseerd. Ik heb nog dingen teruggevonden van mezelf van helemaal in het begin. Dat is wel leuk. Dat kan, dat je zoveel kunt terugvinden. Ja, ja, ja. Dus je kunt een abonnement nemen, los van het lidmaatschap. Maar dan, dat kost 120 euro exclusief BTW voor 6 nummers. Ik heb uitgerekend, dat is 25 euro per nummer. Daar heb je een boek voor. Hè. Dat wel, hè. Dat wel, hè. Maar ik zou bijvoorbeeld geïnteresseerd zijn om nog te lezen wat dat er gebeurt. Maar ik heb geen enkel interesse om nu nog lid te worden van Domus Medica. Maar dus dat is, ja, maar het is goed dat onze bibliotheek het kan terugvinden. Hè? Ja. Maar wat ik bedoelde, Bert, over dat thema, allee, ik heb bijvoorbeeld die richtlijn gemaakt over de diagnostiek van dementie. Je moet die eens proberen te vinden. Allee, die zit niet op onze website, die staat op de website van het expertisecentrum dementie, die ervoor gezorgd hebben dat je dat er wel kunt vinden. Maar ja, ik vind dat nu ook niet de meest geëigende plaats. Dus Ja, maar dat is dan in stukken en brokken. Allee, dat is het volledige document. Zo zijn er nog documenten. Ik vind dat eigenlijk wat jammer. Dus al hetgeen dat er is, dat niet in een artikelvorm zit, dat kun je eigenlijk niet gemakkelijk terugvinden. En ik heb dat gemerkt door mijn poging om Lyria's in orde te maken. En ik vind dat eigenlijk jammer. Ah, wel, we zouden daar kunnen beginnen met dat op onze eigen website te doen. En dat is, wat zeg je? Een bepaalde pagina, ja, ja. Ja. Wel, 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 maar wat dat gezegd had, heb ik jaren geleden al voorgesteld. Ik heb nu een rapportje gemaakt over de CRA's en ik heb gezorgd dat dat een ISBN-nummer heeft. Dat is echt niet moeilijk. Marina kent de weg. Ik heb daar het infectiedraaiboek dat we gemaakt hebben, daar hebben we ook een ISBN-nummer van. Dus eigenlijk zou alles wat je zou kunnen noemen grijze literatuur, zou moeten een ISBN-nummer hebben. Ook al is dat maar 20 pagina's. Dat zou een policy moeten zijn en ieder van ons die mensen superviseert, zou daar een punt van moeten maken. Ofwel is het gepubliceerd in een peer-reviewed journal, ofwel heeft het een ISBN-nummer. Ja, ja, ja. Mhm. Ja. Nee, heel kort. Wel, dat is morgen stagewerkgroep en er is dus iemand nieuw gekomen in de plaats van Christian de Bruin. Hè. Ik heb een artikeltje klaar over het afscheid van Christian. Maar ik heb aan het einde gevraagd van wat haar profiel is. Dat is een gediplomeerde psycholoog die een bijkomende lerarenopleiding gehad heeft en die daar allerlei trainingen in gedaan heeft. Die zit nu stages te verdelen. Dus die zit ver boven haar, onder haar profiel te werken. Ik denk dat de groenen daar nog last van gaan hebben op een gegeven ogenblik. Maar dat soort mensen moeten we misschien wel in toog houden. Maar ja. Ja. Liefst een man, hebben ze gezegd. Dat zijn allemaal vrouwen.
Ja, zeker. Ja, ja. Ja,